My name is Subarna. Some of you will have seen me in Zambia with Sama and myself visited last year. And thanks to the enthusiasm of everyone here, we've been joining in these MDTs since the beginning of the year. And we are alternating, as you know, with teaching sessions and MDT. So this is a teaching session, and Sam has asked me to talk about specialist sickle cell management of acute complications. So this is an old diagram from a long time ago, almost another generation earlier, 2010. And although people no longer differentiate, back in the sort of 2010s, people would think that there are two different types of people, two different types of sickle patients. Some of them who have much more component of infarction, and some people have much more component of hemolysis in their disease. So when I say that, what I mean is there are some people who tend to get more infarction type symptoms, such as acute pain, acute chest syndrome, hyposplenism, avascular necrosis, renal disease, etc. And then some people will be more hemolytic, meaning that they'll run much more lower hemoglobins. They will have pulmonary hypertension, nitric oxide depletion, leg ulcers, priapism, etc. And I think that very stark difference between the two types is no longer fashionable. I think people have not been able to prove, scientifically, experimentally, or otherwise, that actually there does exist two different types of sickle patients. So now I think everyone has a degree of one or the other. But this picture, I've kept it because it's quite helpful in understanding the various ways in which sickle cell can affect somebody. Okay. So hence, there is that huge component of infarction that can happen, pain, etc., nephropathy. All of that is due to that constant, cellular death as a result of hypoxia. And then, of course, the hemolysis itself directly will cause problems such as depletion of nitric oxide, causing endotheliopathy, essentially, and so on. So painful crisis. So there will be some question, like a question answer type thing. Again, I'm not asking anybody. I'm just really to help us navigate this very complex pace. So something that we find in England a lot, and I don't know about you in Zambia, but often, because it is a relatively rare condition in the UK, people are often facing a lot of problems when they go to a health center for pain when they're in crisis. And sometimes people will not believe the patient. Sometimes they will think that they've come here to have drugs. For example, we can give morphine opiates to our patients here. So, sometimes they'll accuse them of morphine seeking. So what we often tell when we talk to doctors and nurses about sickle cell, one thing we are very careful about always mentioning is that if somebody says that they're in pain, I think that is good enough reason for them to receive pain relief. And so in theory, if we were to look at any of these, raised bilirubin, patients say they have pain, increased lactate dehydrogenase, high heart rate, low blood pressure, swollen and painful joints, raised C-reactive protein, proteinuria, renal dysfunction, etc. Any number of these things can result in increased painful, can be an indicator for pain crisis. But for us, certainly in the UK, this is very, very important. And we constantly say this to them is, if a patient says that they have pain, then treat it as a painful crisis if you know that they have sickle cell disease or the patient says that they have sickle cell disease. And apart from that, when there is an acute painful crisis, the patient can have raised bilirubin, they can have increased lactate dehydrogenase, they can have tachycardia because pain can cause tachycardia. Of course, they can have swollen painful joints, increased CRP in the absence of infection. So we do see raised CRP in a sort of sterile inflammation type scenario. So all of these are indicators of painful crisis. So first case, this is a 10-year-old girl. So we'll do some cases. So hopefully that'll be a little bit more interesting than going through just theory. She comes to our emergency department, accident and emergency department. She's on holiday. So lots of people come to, go to various cities to, during the summer or whatever. She says she is in pain, and the mother says she needs urgent pain relief. The child is sitting quietly, not moving, and the hemoglobin concentration is 115 grams per liter, or 11.5 grams per deciliter. So what would be the management? So again, a few choices. Discharge home as hemoglobin is normal. Admit for intravenous fluids, oxygen, opiate analgesia. Or use analgesic ladder and give paracetamol, non-steroidals, codeine if not already given, and opiates if non-responsive. Use both C and plus fluids, or C plus fluids plus blood transfusion. So I don't know if anyone wants to tell me what would be the best approach. So normally what we would do is if a patient has, although we don't know this patient, we don't know their records, we haven't got any idea, they're just a visitor to our hospital. It's a 10-year-old child. They've got a normal hemoglobin. We can sometimes, either you could have hemoglobin SC disease, where you would have a fairly high hemoglobin, or you could be somebody with hemoglobin SS, but on hydroxycarbamide or hydroxyurea, and that would increase your hemoglobin. So high hemoglobin itself is not an indication that they haven't got a problem. And so we would definitely start the analgesic ladder. Sometimes patients just don't remember to carry analgesia with them, or something simple, paracetamol, etc. But therefore, I think it's important to start from the WHO analgesia ladder, which is start with simple analgesia, which in the UK is paracetamol and non-steroidals, such as ibuprofen. That's the commonest non-steroidal that we use, followed by codeine if not already given. And then if non-responsive, or if it's very severe pain, then we straight go onto morphine by mouth usually. And if the patient is very, very dehydrated, particularly usually in the summer holidays, we see this a lot, children playing in water parks or in gardens. So I've come to London and have got completely, dehydrated. So that time, we see that. So pain is the commonest reason for admission. Majority of episodes, as you all know, are managed at home. Very few, there are very few times in a patient's life where they have no other option that patients will come to a hospital setting for pain relief. Either they have uncontrolled pain or they have no access to the analgesia that they need. And we have quite robust guidelines. Again, that's something that we can work on. We are constantly reviewing.
Or not. South of Peters, you drive.
I'm sorry. Shall I carry on? Yeah.
Yes, I think.
Yeah. Sorry. Yeah. So this is our kind of, our local guidance, as it were. This is something that I've borrowed from Dr. Kate Gardner, who is a colleague who works with Dr. Sama. And this is basically what we do. You treat pain as a medical emergency. You give them pain relief within 30 minutes, hopefully, as you come, reassessment, ongoing management, and then be vigilant for other acute complications such as acute chest syndrome or priapism, etc. Sometimes non-pharmacological interventions help, such as heat pads, keeping the patient warm, making sure that they have adequate hydration, food, etc. And then once they're in hospital, after their acute pain is improving, you then step down their management and then discharge home. And it's important to reiterate the families, to take their prescribed medications regularly and be familiar with the analgesia ladder. So this is the supportive management, reassurance, anxiety, stress relief, etc., particularly if the patient is new to the center, they've not been in this hospital before. If the patient is immobile, in children, we don't thromboprophylax routinely, but if they are older teenagers, 16, 17-year-old, particularly with big-sized teenagers, or they're very immobile, or they've got obesity or high BMI, then we would thromboprophylax, and certainly with all adults you would, because sickle cell disease is a very prothrombotic condition. And then, of course, bearing in mind that all of these treatments have got side effects. So opioids will have laxatives, need laxatives, antiemetics, antihistamine, etc. One thing that we use a lot is incentive spirometry in any patient, any child that presents with pain in their chest or below in the abdomen. And this is based on a randomized controlled trial, which showed that actually using spirometry.
Drank it for cold, I left at work, and then I remembered it at work yesterday, and I brought it back home.
Oh, Dr. Mukoko,
yes.
can you mute yourself?
I must have accidentally started.
Okay. So this is just really an idea. This is a percentage point. This was an old study. This is pre-hydroxyurea being prevalent, where they show that, people with HBSS, 38% of patients with HBSS have no pain at all per year. 54% of HBSC have no pain at all per year. And you can see that gradually it reduces, obviously. So there are very few, only 2% of SS patients have more than 6 pain episodes, and so on and so forth. So there is still quite a lot of, 38% of SS patients have no pain event, which means that, 62% of people, so there's a huge majority of patients will have at least one pain event per year. So moving on to the next case. So this is a 7-year-old girl with hemoglobin SC disease, and she presents to the A&E department unwell and very irritable. She's kind of a lot of distress, and she's got pain in both of her legs, and she's got high temperature of up to 39 degrees, and she's tachycardic. So what is the management? So are we giving paracetamol, intravenous fluids and pain relief, blood cultures and antibiotics? Blood cultures, antibiotics, fluids, pain relief, paracetamol, or blood transfusion. So in this case, who is a 7-year-old child with SC disease, but also got high temperature and pain, is tachycardic, we have to treat them as a potential infection, as well as treat their pain. So blood cultures before you start antibiotics would helpful, although it is very, very unusual for young children with SC disease to come in with very severe, sepsis type condition. Although, it's never say never, these things can happen in SC as well. So we tend to be cautious, and we will give them, more often than not, these are viral infections rather than actually, a pneumococcal sepsis. In the UK, we see malaria in the children returning from holiday to malarial countries. So we would often see them in September, October, or just at the end of the Easter holidays, etc. So we are vigilant. But of course, if your child is in a malarial endemic country, then of course, malarial infection becomes topmost in your differential. So these are the bacteria that are prevalent in sickle cell disease, as we all know: meningococcus, pneumococcus, salmonella, Haemophilus influenzae. Well, the salmonella, usually the non-typhi salmonella, tends to be the more common, particularly causing bone problems. Again, for the UK doctors, it is helpful to have a malaria history, prophylaxis history. But of course, in somebody who is in a malarial endemic region, this would be routine practice for them to look for malaria and to check if they're on prophylaxis or not. Okay, febrile patient with sickle cell disease. Young patients usually vulnerable to infection with encapsulated organisms. Hence, we tend to identify them at birth and give them penicillin if we can. And I know that that is something that is beginning to happen and has been happening in many countries in Africa as well. Screening at birth. It is a hyposplenic state, autoinfarction of their spleen. 90% of sickle cell SS patients between the ages of 6 months to 3 years experience hyposplenia. It would be recommended to start penicillin for 3 months of age and allow for additional vaccinations, including Prevnar. And we do have a low threshold for admission and treatment for infections, especially if less than 2 years of age. When we looked back at our patient cohort in the UK, we found that almost all the children who died of infections were less than 2 years of age. Almost all the children who were not a neonatal death due to prematurity or whatever, tended to be children who were not taking penicillin prophylaxis or were not being vaccinated. So the questions to ask in this situation is, what is the focus of this infection? Are they taking a prophylaxis, malarial prophylaxis or penicillin prophylaxis? Is there vomiting, for example? Sometimes vomiting can, make them vomit out their penicillin prophylaxis, and it's possible that that could be a source where they can get an infection. Travel history is relevant, and transfusions. Have they had a transfusion, and is that what's causing this problem? And of course, if you've got tissue infection, that could be where the tissue ischemia, that could be an nidus for infection. So low threshold, particularly less than 1, or, definitely for less than 1 and also for less than 2. If there is respiratory symptoms, we would always take a nasopharyngeal swab. We do power serology, but I appreciate that not everybody will have access to these tests. Chest X-ray, definitely if there's low oxygen saturations, respiratory symptoms, we would do a malaria screen if there is a positive family, positive travel history. Sometimes if the child is on regular blood transfusion or an iron chelation, we would want to look at their stool and blood for Yersinia, which is a bacteria that likes to live in iron-rich environments. And we would definitely want to give antibiotics in a child who's having high temperatures. Usually doubling up penicillin prophylaxis does not work in this case, or just giving paracetamol enough may not be effective if they've got ongoing bacterial infection. Okay, so this is the next case, 7-year-old girl with a HBSS. A very high achieving family. They want their children to do very well, but unlike the 2 siblings, this child is not doing very well in school. They tend to not be able to focus. They are very distractible. And then suddenly they have a dense left hemiparesis, sudden onset. Although their Glasgow Coma scale is normal, the transcranial Doppler monitoring did not show abnormal results, but still not normal, but not abnormal either. And the CT scan of the brain, which was done urgently, showed this right-sided large infarct on the watershed area, as can be seen in this picture. And the child then went on to have an MRI scan, including an MR angiogram. And if you see the left side on this picture, let me just pointer. If you see the left side, this is the middle cerebral artery on the left. You can see the full length of the artery, nice and wide and white with the contrast. Whereas you can see here that there is nothing going, it's completely narrow. And there's a point where there's virtually no dye going through. And that's basically the point where that obstruction has happened. So cerebrovascular disease in sickle cell disease is very common. Before the era of transcranial Doppler monitoring and transfusions, we know from Kwakyo Frimpong's work in the US that 11% of sickle cell patients had a stroke by the age of 20 years. However, unlike every other complications in sickle cell, stroke seems to be something that does not worsen with age. It improves with, well, as in the risk does not worsen with age. The younger you are, the higher the risk is of developing a stroke, and the highest risk is in the first year of life. So in a untreated group of patients, there would be between the ages of 2 to 5 years, about 1% of children will have a stroke, which is very, very high compared to, say, somebody who hasn't got sickle cell SS. And then that reduces to 0.79 per 100 patients years and reduces to 0.41 between the ages of 10 and 19. If left untreated, strokes will recover in 2/3 of patients within the first 2 or 3 years after the initial event. So anybody who has a stroke will definitely have another stroke, or the chances of having another stroke in the next 2 to 3 years is extremely high. It's up to 67% of your patients who've had a stroke will have another stroke within the next 2 to 3 years if nothing can be done about it. And as I said below, children with sickle cell have 300 times higher risk of stroke compared to non-sickle population. So how do you manage case 3? Aspirin and thrombolysis. So remember, they presented with a sudden onset acute infarction with dense hemiplegia and a completely blocked right middle cerebral artery. How would you manage this patient? Aspirin and thrombolysis and blood pressure control, urgent exchange transfusion and thrombolysis, urgent exchange transfusion, thrombolysis, and aspirin. So our answer is just urgent exchange transfusion. So if this patient just needs urgent reduction in their sickle percentage to less than 30. We do not use aspirin or any other type of thromboprophylaxis or thrombolysis in these cases because the pathophysiology is not cardioembolic, like older patients with sickle cell or an older patient in normal population might do. This is very specifically something to do with cerebral vasculopathy secondary to sickling or sickle cell disease, and therefore the mainstay of treatment would be exchange transfusions and maintaining ongoing transfusions to keep their sickle percentage less than 30. So what is the role of transfusion here? So normally there's raised cerebral blood flow velocity due to severe anemia, vessel stenosis, cerebral vasodilation due to tissue hypoxia. Transfusion reduces the cerebral blood flow velocities by correcting these abnormalities, and it also reduces sickling and ongoing damage to the the large vessels in the brain by reducing the sickle percentage. And if left untreated, many will be, more than 67. I mean, here it says 90%, but many children will have another stroke. So a transfusion therapy to keep sickle percentage less than 30 causes reduction of this recurrence to less than 10%. So just to really remind people that transfusions will not stop people from stroking 100%. So there will still be a small percentage of children who will continue to stroke despite being on transfusions. So that's something to bear in mind. So if you have a child who's having transfusions, perhaps there's something, and they come in with a stroke or come in with symptoms that are suspicious of a stroke, you may want to think about that this could be a second stroke. So TCD monitoring is something that we are able to offer to children here in the UK, and the magic number is 200 centimeters per second, and it's got if the numbers are more than 200, then they have a very, very extremely high risk of developing stroke, and therefore ideally you would want to start them on hydroxyurea so that it doesn't get to that stage in the first place, and more recent data has supported that use of hydroxyurea. And this is just the stop trial data. It's it's kind of hugely impactful and practice changing research, which shows that there's a 90% risk reduction if children with high transcranial Doppler velocities are started on regular transfusions. And this transfusion can happen by exchange or top up. It doesn't matter. Really, the mainstay of the transfusion purpose is to keep the S percentage below 30 if possible. And obviously this meant that it kind of changed the way we did sickle medicine really after this study was published, because we then started thinking about universal transcranial Doppler monitoring for all our patients. Okay, I've got quite a lot to cover, so I'm just going to quickly move on, and then maybe questions at the end. We've got another case, 13-year-old boy with HBSS, sorry about the typo, presented with groin pain, okay, treated with analgesia. The next day, so nobody actually examined him, and this is a true case actually. He was saying that he has pain in his groin, and he didn't actually say that he had priapism. So he was treated, he was given pain relief, he was probably encouraged to drink. I can't remember whether he was given intravenous fluids. And when the consultant came to review him the next day, actually it was realized that the child has been getting all these priapic episodes right from when they were admitted. And this led to a long-term erectile dysfunction because of the duration in which the priapism was left untreated. So this lesson for us is very important, that if somebody has groin pain, or firstly, you know, when patients are told about priapism, sometimes patients just do not feel comfortable about talking about penile erections. They don't feel comfortable bringing it to medical attention, or sometimes they may not even make the connection that it has anything to do with their sickle cell disease. So we are increasingly kind of doing a little bit more discussion about erections in clinic when we see the patients. And then if a young man, a young boy or a man complains of groin pain, it's, you know, you should ask them, you know, do you have a painful erection? Is that what's causing your groin pain? Because if you don't, then, you know, this patient will have long-term damage. Priapism is defined as persistent, painful, unwanted erections. It's not your normal natural erections. Many patients with sickle cell disease will have it, although not everyone will have a problem with it. Some people will have very short-lasting ones, the stuttering one. And of course, the fulminant priapism is the problematic ones where it lasts for more than two hours. And this causes the risk of erectile dysfunction in the long run. So how do we manage priapism? So exchange transfusion and pain relief, epinephrine and aspiration of the penile shaft if the priapism does not settle. Urgent urology referral for aspiration, analgesia, fluids, exercise. And E, analgesia, fluid, exercise, epinephrine, and aspiration if not settled within 2 hours. So exercise is important in priapism, because what happens is you've got all that blood rushing into your vein, into your penile artery, sorry, and then the draining of the blood back into the body through the penile vein is not happening. And so in order to increase the blood flow out of the penis and into the body, just doing some physical exercise, running up and down the stairs, you know, getting that blood flowing back into the body is helpful. So we have some patients in our clinics who, you know, will go up and down, you know, they can predict that they will have it. And this one extreme case we have is where the gentleman, he's not a child, he's an adult. He sets an alarm for about 3 o'clock in the morning, where he and his mother will go out for a walk, or you know, his mother will stand and he will go for a run in that time of the morning, to stop him from getting a penile erection first thing, you know, later on in the morning. So it can be, although on the face of it does not seem like life-threatening, of course it's not life-threatening, but it can be very, very debilitating for the patient. And so the answer is everything. So number E, pain relief, you treat it as a pain crisis. Fluids, as you would treat a pain crisis. Exercise, for the reasons I've just explained. Epinephrine is a drug that we use, alpha adrenergic drug, which is available in the UK to use. It can help. And penile aspiration if things are not settling with time. And we don't do them ourselves, or the A&E doctors don't tend to do them, particularly in children. They do block anesthesia, and the urologists usually will aspirate, although it's not a technically very difficult procedure to do. If anyone has done them, you will know what I mean. You just sort of put in a needle and aspirate the blood from the shaft, the corpora cavernosum. Okay, so management of priapism, acute priapism, pain relief, alpha adrenergic agent like epinephrine. Urgent urology review is what we would do here in the UK. If it's ineffective, then sometimes they will have to do a shunt procedure. And we have occasionally needed to do it in children, but not that common. Chronically, priapism can be very, very problematic, as I was telling you earlier. You can have long-term adrenergic events, agents, some hormonal treatment, including PDE5 inhibitors such as Viagra. So sometimes it's sort of counterintuitive, but actually it does help with recurrent chronic priapism. And basically it's not very clear if disease-modifying agents like hydroxyurea or blood transfusions help. But there isn't a single patient who has chronic priapism who is not on some sort of disease modifier, because you try everything in your power to try and reduce the sickling if you can, so that by extension, you will hope that the penile priapism the priapic episodes will improve. Next case, 8-year-old girl with sickle cell anemia, SS, presents with shortness of breath and new hypoxia. What are the differential diagnoses? Pulmonary embolism, chest infection, acute vaso-occlusive crisis, acute chest syndrome, cardiac failure, pulmonary hypertension. Remember, she is 8, okay? New hypoxia and shortness of breath. So when I say new hypoxia, obviously she's had a, an oxygen saturation levels done before, which was normal. So, if you've got, so I guess the answer, would be either a chest infection and an acute chest syndrome, but if you're hypoxic, and you've got chest pain and you've got chest X-ray changes, it is acute chest syndrome in a child with sickle cell. So acute chest syndrome definition: signs and symptoms of respiratory disease, such as chest pain, fever, wheeze, shortness of breath or cough. And number 2, new radiological evidence of consolidation. Remember, hypoxia is not in the definition of acute chest syndrome, although we use hypoxia very commonly to guide treatment. So for some reason, it's never been included in the diagnosis of acute chest syndrome. But however, it's only second to pain for being the most common cause of admission to hospital. And in the first 10 years of life in sickle cell anemia, SS, about a quarter, or 25%, will be admitted with acute chest syndrome, unless there is universal coverage with hydroxycarbamide or hydroxyurea. So 40 to 50% of patients who are present with acute chest syndrome initially admitted to hospital with pain. So this was the study from more than a lifetime ago. Well, it's 25 years ago, Vichinsky's New England paper from the US in year 2000. And since then, there has not really been a particularly high, a kind of a repeat of that major study on chest syndrome. But what the paper suggested was that about half of the patients who eventually develop acute chest syndrome will not present with acute chest syndrome. Instead, they will present with some other pain, usually affecting their chest, their ribs, or their abdomen. Sometimes sedation from analgesia can cause hypoventilation and worsen chest crisis. Infection, fat embolism syndrome, which can be really problematic and painful and can cause devastating complications. Obviously, vaso-occlusion of the pulmonary arteries by sickled red cells. Sometimes, in many, many patients, no specific cause is identified. And I believe there is an increased risk with smoking in adults. Infection, again, this is an old study, but although the newer studies, particularly with children, particularly in Europe, suggest that the rates of viruses are much higher and the chlamydia rates are not that high at all, the chlamydia pneumoniae rates. So based on this sort of infectious profiles, we almost always give a macrolide, so either erythromycin or azithromycin, to cover atypical pneumonia or community-acquired pneumonia such as mycoplasma, chlamydia. But actually, that is not borne out by the more modern data from children certainly in certain European countries. But so the jury is out there whether that is the right choice of antibiotics or not. But Streptococcus pneumoniae does happen. And, every day we see one or, very frequently, not every day, but frequently we see patients with sickle cell anemia being admitted with streptococcal pneumoniae, either in the form of sepsis, meningitis, or chest infection. And of course, these, as I said to you earlier, these generally tend to be children who are not on penicillin prophylaxis for whatever reason, or not being vaccinated. Of course, tuberculosis, atypical mycobacteria, salmonella can all cause this. And in fact, when we had a influenza pandemic a few years ago, about 10 years ago now, H1N1, swine flu pandemic or epidemic in the and many patients had acute chest syndrome back then. So we know for a fact that influenza infection can really severely affect patients with sickle cell, and therefore we highly encourage people to get influenza vaccination if they can. And then management is all of this, analgesia, incentive spirometry, is basically just a chest physiotherapy, which was shown by a randomized controlled study in the 80s to prevent patients with abdominal pain to develop acute chest syndrome. And then antibiotics top up versus exchange. Early top up is just as just as effective as a late exchange. And sometimes it's quite good to be proactively, transfusing if possible to stop things from getting worse. Oxygen, of course. Physiotherapy, just to help the breathing. So respiratory physiotherapy. Steroids can help, and we now increasingly use steroids in severe patients. And this is the prevention of acute chest syndrome. Of course, in the ward, we use this incentive spirometer. When children who cannot use the incentive spirometer, or if you haven't got access to an incentive spirometer, we encourage children to blow bubbles. Although that action is blowing action, the spirometer is breathing in action, but at least there is a form of respiratory exercises. Of course, hydroxycarbamide is the best preventive agent for acute chest syndrome, and this was borne out with lots and lots of studies. As you can see, hydroxycarbamide helped everything: hospitalization, but with pain episodes per year, acute chest syndrome, need for transfusions, all of them had improved whilst on hydroxycarbamide or hydroxyurea. And this was the baby hug study, which also did not meet the primary endpoint of organ function, but actually showed improvement in many aspects, such as pain and hospitalization and need for transfusions, dactylitis, etc., etc. And these were very young children. And that led to the universal provision of hydroxyurea to children from the age of 9 months onwards who have SS and S-beta-0 thalassemia. I'm going to skip that. Yeah, chronic respiratory lung disease, it may happen with recurrent acute chest syndrome. Fat embolism syndrome is more common in adults. It can sometimes be, we see fat embolism in trauma patients as well, not non-sickle trauma patients, where they have like trauma to their bone marrow and then bits of the bone marrow splinters out into the bloodstream, causes the embolism of the fat from the marrow and wedges into the bloodstream, into the pulmonary vessels, and causes severe acute respiratory distress syndrome. And the similar thing can happen in sickle cell disease in the absence of trauma, particularly if you've got very severe vessel occlusion, that can happen. And that releases fat into the blood, blocks the pulmonary vasculature, and this can cause not just acute respiratory distress and acute chest syndrome, but can also then be into the brain and cause very typical MRI findings on the brain and cause encephalopathy and so on. Okay, Chair, do we have time? Sorry,
We've got 20 minutes. Yeah, keep
20
going.
minutes. Okay, thank you. So another case, a 3-year-old with SS who has got increased lethargy. She's just not feeling herself. About 2 weeks ago, she had a viral illness. She looks very pale and her hemoglobin was 3 grams per deciliter, 30 grams per liter. So what are the differential diagnosis? So differential diagnosis in somebody, it'll be helpful to know what the reticulocyte count is. If the reticulocyte count is very low, then it's a hypoplastic anemia, likely to be an aplastic crisis from parvovirus infection. That is the common, we have seen like a epidemic of parvovirus in the last year in the UK. And this is appears to be a post-COVID manifestation where children have not been exposed to parvovirus in the last few years. And then all of a sudden parvovirus is the rage. Every child is having parvovirus infection. Of course, if you haven't got sickle cell, the parvovirus is just a minor viral infection that gives you slap cheek syndrome. But if you've got sickle cell or any other chronic hemolysis, you will end up with much more severe problems. So we would give them a top-up transfusion. You would want to really palpate their spleen, do a reticulocyte count, do parvovirus serology if you have access to that kind of stuff. Of course, you don't need to do emergency splenectomy. So I would say that the answer would be to do that, but of course, they would also need a transfusion. Acute anemia, spleen and reticulocyte count. So this is important to try and understand acute anemia. Why does a child come in with acute anemia? So it would just very helpful to know when they are well, what the size of their spleen is, because that really makes the biggest difference. If their child is not known to have a splenic enlargement and they come in with a massive spleen and low hemoglobin and they've got high reticulocyte count, you know that what you're dealing with is probably a splenic sequestration, either an acute sequestration or maybe a chronic sequestration the last time since the last time you've seen them. If it's a lack of production, such as in parvovirus infection, your reticulocyte count will be low. So even if you don't have access to, let's say, parvovirus serology testing, if you had access to reticulocyte count, which I know that you may not have, so I think just looking at a blood film to see if there is high evidence of polychromasia on the blood film, because a child who is very acutely hemolyzing will have massive polychromasia on the blood film. So if you see polychromatic cells on the blood film, or on the other hand, if you see no polychromatic cells at all, then that gives you a very good idea of what you're dealing with. So hypoplastic versus actually sequestration. In the sequestration scenario, your bone marrow is going overdrive, it's making a lot of cells, but of course the cells are being sequestrated either in your liver or on your spleen, usually in the spleen. So reticulocytopenia is a common feature for a parvovirus B19 aplastic crisis. They can present with abdominal pain. Quite commonly, I've seen that. Respiratory symptoms, fever. Of course, it's a very high risk to pregnant women, all chronic hemolysis patients and immunocompromised patients. The patient will take some time to recover from an aplastic crisis. And sometimes the anemia can be so severe that they cannot survive without actually an additional top-up transfusion. Eventually, they will clear the virus with their natural immunity. It takes about 7 to 10 days to do so. But if you don't top them up, then they may become, they may run into huge problems. It's important to keep an eye on somebody who's got, relatively low hemoglobin and probably an inappropriately low reticulocyte response. And of course, don't forget the siblings who may have also sickle cell disease. If it's a highly infectious agent, so if a child has got parvovirus crisis, chances are that their brothers and sisters will have the same. And if one of them has sickle cell, you need to check their hemoglobin as well. Aplastic crisis, parvovirus infection, I like to tell families that it's a bit like chickenpox. Once you've had it, generally, unless you have a problem with your immunity or nephrotic syndrome or severe renal disease, you generally tend not to get it again. So once you've had it, you kind of you've got lifetime protection. And splenic sequestration, of course, the opposite of that. You get anemia, but you get reticulocytosis. Your spleen will go bigger. It will be painful because the splenic capsule is very, very sensitive. It's got many, many nerve endings. You can, if it's sudden, have a hypovolemic shock. This can cause sudden death. And although it says that it generally tends not to happen beyond 6 years, but increasingly we see older and older children with SS with it. And that's partly because many of these children are on hydroxycarbamide, hydroxyurea, and that tends to be protective. So their spleens are not autosplenectomizing that soon in life, and therefore there is more room to have splenic sequestration. Sometimes we see these kids coming back in again and again with acute splenic sequestration. They've had once and then it gets better and they have a transfusion, then comes back and then has another one and so on. If somebody has one, we generally tend not to do anything much. But if they have more than one, acute splenic sequestration crisis needing, causing life-threatening anemia, needing blood transfusion, hospitalization, etc., we would refer them for a splenectomy for sure. Sometimes this is so severe that they tend to come back every 2 or 3 weeks for, an acute drop in their hemoglobin. Then we will keep them on transfusions for a bit until we can get them onto surgery safely.
Case Quench about hospital.
And then I'm going to skip this. So there's loads of biliary problems. So acute complications we've covered, painful vaso-occlusive episodes, acute chest syndrome, severe acute anemia, susceptibility to infection due to functional asplenia, hepatic complications, priapism, and stroke. And so there I end my presentation. And I'd be very happy to take questions if you feel that I can help with anything.
Amazing. Thank you very, very much, Subarna. That was excellent. and very, very comprehensive. I wonder if anybody has any questions or any comments. Please feel free to unmute yourself and ask away.
Can I just ask the Zambia colleagues about a case where, patients come in with acute hemolysis? Can somebody maybe just talk to me about the approach that you would normally take with somebody with, maybe dark urine, acute hemolysis, low hemoglobin, non-sickle patient, how you would approach that patient?
Hi, Subarna. Yeah, that's a great question, and we really do have those cases, but I am always the one speaking in the meetings. So I want one of my, or any of the other team members, any of the registrars who can speak to this, especially the ones in the hematology unit. Leila, Namwaka, we've had a few cases of this in the past weeks. Are you able to just outline? Okay, well, we may have lost them. So we do have.
Hi, Dr. Taylor.
Great. Thanks, Namwaka. Go
Sorry, I
ahead.
was telling to unmute my mic.
Okay. Go ahead, Namwaka.
I'm just trying to clarify if I had the question right. Is it about hemolytic crisis?
Yes, so basically,
my question was just your approach to a child who's presented with sickle cell, non-sickle cell patient who's presenting with acute hemolysis, either with just jaundice and severe anemia, or maybe jaundice and dark urine and severe anemia. What kind of presentations do you normally see? What would your thoughts be in terms of investigating those children, and how do you approach the child's management?
Yeah, so we quite see most of them would come as just a VOC, then once on the ward, they start hemolyzing, they get jaundice, they get dark urine, they start desaturating. So for such patients, we start with basics. Of course, we're going to do the full blood count. Our main interest would be to look at the hemoglobin. Then we'll also go ahead and do the LDH, of course, even the liver function test. Then we would want to do the urinalysis, of course. And then we would want also to do an abdominal ultrasound as well. Then we have a protocol that we use for treating these patients who are hemolyzing. Yeah, so our protocol involves starting IVIG, the hemoglobin IG. Then we also put them on methylprednisolone. We closely monitor them and do a daily urinalysis as well. And we also initiate them on erythropoietin. And then we hold on any blood transfusions because they are hemolyzing, and there will be no point of giving them any BT because they'll continue hemolyzing the transfusion you're going to give them.
So my question is that, you've approached a child with hemolysis or worsening hemolytic anemia, let's say. Somehow their sickling or their hemolytic anemia is worsening, is what we've just discussed. So a patient who's come in with initially a simple vaso-occlusive crisis episode, they may also have an associated infection or a chest crisis, as you've described. And then you've discovered that the patient has dark urine, not black urine, but dark yellow urine, so lots of bilirubin coming out of the urine. And you're seeing that the patient's hemoglobin is dropped. If you do a blood count, you've seen that happening. And what makes you think that the patient needs immunosuppression at this stage and not a transfusion? That was my question. Why do you immunosuppress them rather than transfuse them?
So anyway, this is just my thinking. So these patients, when they come, initially they already are hemolyzing. So by the time they're showing that jaundice and the dark urine, to say, they would have started hemolyzing in a long time. Yeah. So another reason would be these are patients who have received multiple blood transfusions. So they might have developed some antibodies. So when they're in that state already hemolyzing, then you also put the blood, give them blood transfusion. That will just exacerbate the hemolysis due to the antibodies that they have developed over the previous times they've received the BT. That's what I think.
Okay, thank you. I don't know, Chilo, if it's possible for your, this is something that might be worth sort of exploring a little bit more, just to see, would you do a malaria, presumably you would do malaria screen just to make sure there's not black water fever that you're dealing with and all that. Yeah, I wonder whether it's worth doing a look back, some sort of an audit to see how frequently these things are happening, and then whether that might be a nice an MDT discussion at some point if you've got these patients. You know, if we can do like a case series of these patients in a future MDT. I don't know what people think.
Actually, that's a good idea, and I think as Namwaka has highlighted, of course, one of the concerns we have, because even when we have the blood products coming from our blood bank, they are not complete. They are not always completely depleted. So with the patient that has been having repeated blood transfusions, that's the major concern that we have, that before we give them a transfusion, we need to ensure any alloantibodies or autoantibodies have been neutralized, and hence the direction of giving either pulsing them with methylprednisolone first or IVIG, whichever one is available, and depending on the severity as well. But we do eventually give blood transfusion, but we do that as a first step. And some of the investigations that we do are those ones that you've mentioned, Subarna. We initially think this is probably infection triggered as well. So do an infectious screen, septic screen, which also include malaria, especially that we are quite endemic. But I like the idea of the hemolytic, looking back, doing an audit and seeing our practice, what could be some of the triggers, because I think we use a lot of anecdotal data. Yeah. So I'll speak with the team and see if we can look into that. Yeah, that's a great suggestion.
Dr. Tielo, this is Dr. Mwandama from the adult hematology unit.
Welcome, Dr. Mwandama. Please go ahead, Dr. Mwandama.
Yeah, so on the adult hematology side, what we normally do is we would also want to do a direct antiglobulin test or Coombs test. So if it's positive, then we'll usually take the route of giving IVIG and methylprednisolone. Although all things being equal, we would want to do an extended cross match. If DAT is positive, normally the DAT is polyspecific. Is polyspecific. We'd want to do a monospecific DAT so that we try to establish which antibodies are involved, whether it's IgG, IgM, and then we would also want to know which particular antibodies, the minor antigens like Kelly, Duffy, or Kiddy, those we would want to do those, but in our setup, it's quite difficult to do the other cross match to try to type what autoantibodies are really involved. But at least we do strive to do a direct antiglobulin test or Coombs test, and then if it's positive, we go ahead and give IVIG and methylprednisolone. Yeah, we would have loved to look for the actual autoantibodies that are involved.
Thank you, Doctor.
Thank you, everybody. I think it will be very important, as Subarna suggested, to have a look back and present and discuss these cases, purely because of the morbidity associated with it, and also the variability in the lab testing capacity available in different parts of the country. So just wanted to say that the July session is actually dedicated for sickle cell transfusion and the delayed hemolytic transfusion reaction, as well as hyperhemolysis. But of course, we're welcome to discuss that in any of the next upcoming MDT sessions if you have a particular collection of cases.
But if we're in March now, summer, so we could potentially have, 3 months that the team could then go off and do that look back and then aim for the July MDT to discuss it. I think that gives quite a nice opportunity for the team, for Tilo's doctors, team to look at the cases. Yeah.
Absolutely. Yes. Oh, somebody's got their hand up. Please go ahead. Dr. Namwaka?
Oh, yes, please. I was just asking if you could kindly share the PowerPoint so that we could go through it on our own time as well. Thank you.
Sure, no problem.
Just to add, this recording will be up quite soon on the Zambia Task Force page on our BSH website. So all of these MDT series or sessions the videos will always be up. Give it about, say, 2 weeks, 1 to 2 weeks around from when we've had this session. So not to worry about, missing out on anything, because you can just re-watch that recording.
Thank you so much. I think that's very helpful. And just how to find the page is simply by Googling BSH Zambia, and you'll be finding the link to the page where the videos will be recorded under a tab called Zambia 2025. Very good. Thank you, everybody. Any last questions or comments?
I'm just adding a link to the page now. So if anyone wants to just keep that tab on their, browser for the future, it will be on this page at the bottom of the page, and it's as a YouTube video, so can watch anytime.
Wonderful. Thank you so much.
You're welcome.
There's a question in the chat.
Someone's got their thumb up. Don't know if that's a
Oh yeah, this
question.
question is about how long do we give methylprednisolone before you can transfuse if the HB is really low in hemolytic crisis?
So, I mean, I'm caveating this completely, knowing that we have access to testing that you won't have in Zambia. So in somebody that comes to our service, if they come to clinic, come to our hospital with an acute hemolytic crisis, we would, perhaps not always treat with methylpred and IVIG, because we have the luxury of testing, as as the previous speaker, Dr. Capella, mentioned, that the DAT would be something that you guys would do, and we would obviously have an access to alloantibody screening straight away. So we would know, and sometimes we're very lucky because we have historical antibody responses as well. Sometimes the very, very good question, sorry, I'm digressing a little bit, not directly answering your question, but what I'm saying is that sometimes, we have a very straightforward connection to a previous transfusion episode. So somebody might have had a transfusion 2 weeks earlier for something else, and they come back later with an acute hemolytic crisis where they have dark urine, low hemoglobin, sometimes with even low reticulocyte count. Now, in that situation, before we give anything, we would want to do an alloantibody screen. And sometimes, and again, I'm caveating this because I know that we have access to this and you won't, but in an ideal world, that's what you would want to do. And we would give, if we are giving methylprednisolone, we would probably just pulse it. We just give 1 dose. But sometimes we, so it could be a very high dose of methylprednisolone, 0.5 grams or 1 gram per kilo, or 2 milligram per kilogram. Nobody knows what the right dose is. So sometimes I've given 2 milligram per kilogram. Some of our adult colleagues would give much more than that in that scenario, where you're basically dampening the alloantibody response to somebody who has a delayed hemolytic transfusion reaction. But if somebody does not have a recent history of transfusion, then we would just give them a top-up transfusion and then hope for the best without immunosuppressing them, just knowing that, they've come in with an acute hemolytic, because, in the end of the day, if you've got an acute infection, let's say you've got sickle cell disease, you've got an acute infection, you've come in with hemolysis, because that's what people do. If you've got sickle cell disease, you come in with hemolysis because you're sickling a bit more, because you've got an infection that's causing you to sickle a lot more. And that's why you're seeing these increased hemolytic markers, etc., anemia. That is very, very common in sickling. So not all of them will need immunosuppression. That I can always say, I'm caveating this, or I'm sort of backing this up by saying that, look, we have the luxury of checking alloantibodies, etc. Quite what you would do in the absence of that, I don't know. But, just something to bear in mind, that sickling is a normal thing in hemolysis, in infection, let's say. Sickling is a normal thing to do if you've got an acute chest syndrome. You would sickle, you would hemolyze, because that's what people do. Whether every time what you're dealing with is an alloantibody reaction somehow, or a delayed hemolytic transfusion reaction, or some sort of hyperhemolysis, I don't know that. I don't know. That's why I think it'll be helpful to know when you do your look back to see, the patients that you're seeing with these acute hemolytic episodes, what else are they coming in with, or have they had a previous episode of transfusion, and things like that. But a direct, simple answer to your question, I would say, yeah, we would probably only give 1 or maybe 2 doses of methylpred. If you give more than that, you would probably want to then give a short taper with an equivalent dose of prednisolone orally, because you don't want to give, because if you give too much pred and you just stop it, then sometimes it can give rebound pain crisis. So yeah, so that would be a long-winded answer to your short question. Sorry about that.
Yes, thank you. And just to echo what Subarna said, we do the same. I think we just give 1 or 2 doses of methylprednisolone, but almost never more than 2, and would give them over 2 days. As she said, also very high dose, actually, we'd give 10 milligram per kilogram if there's very aggressive hemolysis, along with 2 doses of IVIG at 1 gram per kilogram. Again, 1 or 2 days maximum, and then manage the hemolysis with other ways. And thanks to other testing, we're able to identify what kind of hemolysis we're dealing with. But thank you very, very much.